Hello everyone, welcome to online classes here in the Surgery channel. Today I want to share with you a case that actually presented yesterday. And this was a patient that came as an emergency patient. As you can see in the panoramic view, it's a patient that has suffered from a lot of problems. Reconstructive surgeries have been performed in his maxilla, upper maxilla and lower maxilla. Different types of implants have been placed in other clinics. This is a patient actually travels around the world for a long time, has been traveling for a long time, and usually he's being like, trying to fix the problems as the time goes by and as the problems come up. What actually he was complaining about was about this screw loosening, and these two first molar and second premolar, upper right first premolar and second premolar and first molar, were loose. As soon as I see a structure over implants that gets loose, it's important to try to check which is the problem. Not only diagnose the screw loosening as an event that may happen because it's a screw that goes into an implant or a screw that goes through a prosthetic abutment and then it screws into the implant. We should try to focus on the cause of the problem. And usually, and most of the times, just like when the patient develops periimplantitis, the screw loosening or the structure that gets loose has a multifactorial effect. I strongly recommend that when we see cases like this, that actually you see a structure that is moving, try to check different factors. One of the factors would be the non-occlusal control. When the patient has a non-occlusal control and there is an unbalanced bite, obviously, this is not a functional bite. This is not a soft relationship between the uppers and the lowers. If the patient actually has a perfunctional habit as well, it's another factor that gets added to the other factor that might increase the problem. And it's a multifactorial effect, and it's a chain of events that will create or will end up developing the problem that we actually see in the office. So I strongly recommend to go to the bottom of the problem. Try not to see the iceberg from the top and try to see the iceberg from the bottom. And in this case, what I wanted to see was first, obviously, I took this photograph because you should have a clinical control. Obviously, we are going to see in the mouth, we're going to check in the mouth what's going on, which is the problem. Is there any pain added to this problem? And the patient was telling me that there was no pain. But what I saw here was a redness around this implant. And as soon as I see redness around an implant, and it's related to the panoramic view, and I see some bone loss here, related to the posterior area of this implant, number 16 or upper right molar implant. Besides the other problems, besides this misfit of the structure, this is a splinted, cemented retained, two crown retained, cemented retained structure, I see other problems as well. So it's very important that we understand the problem of the patient as a whole and not just as a single and particular problem that the patient is referring, but also collateral problems that the patient is not aware of and that we need to diagnose. This is like CSI situation. Most of the times when the patient comes to the clinic for a problem, you see another problems actually related to that problem or that have nothing to do with that problem. But it's very important to diagnose every single thing that we see in the mouth that might represent a risk of development of additional problems to the patient. So what I see here is a bone loss as well. And not because I'm not a prosthodontist, I'm a surgeon, but I need to assess the patient about this problem. So when I make a pressure on this area, what I see is a little fistula here in the apical part, and I see some suppuration as well. And some suppuration is coming out from this gingival margin. So there is a mucositis, there is a suppuration, there is a bone loss, there is a periimplantitis, there is a mild progressive periimplantitis that is developing because of what? Because of lack of bone, because of the residual cement that at the moment of the crowns that were cemented, maybe they did not control the excess of cement that usually gets stuck in the gingival margins or in the preimplant tissues. So not to see the problem from the bottom might represent a very big risk of allowing a progressive problem that will continue developing new problems down the road. So what I tell the patient, is this redness, is this bone loss caused because of the micro movement that you've been experiencing because of this screw loosening that one of the implant has, and that misfit that you see in the x-ray? Could be because when you have a structure that is micro moving and it's a certain amount of pressure over the tissues for a long time, it might represent a chronic inflammation around an implant or around the tissues that the structure is pressuring also all the time. So if you make a continuous pressure for a long time, and especially the patient that only bites on the right side, because on the left side he's aware that he's missing two important teeth, you are like continuously increasing the problem, because that structure that it's moving is generating an inflammatory tissue because of this traumatic problem that it's being developed over the gingival tissues. So I take a periapical x-ray because I want to see the area a little bit closer. And one of the things that I see, obviously, is the absence of the screw here. There's no screw. No screw here, misfit here, and non-passive fit of the metal structure of these two splinted crowns. So I have to think at this point, what developed this screw loosening? I don't see any screw. Is there anywhere? Did they place a screw here? Were they missing a screw and maybe they just put the screw here and they cemented everything? I don't know. I don't think so, because you need to screw this prosthetic abutment. So when we see these kind of situations, you have to guess, maybe the screw is right here. Because of gravity, the screw got loose and then it fell into the prosthetic space of the abutment. So I tell the patient, listen, we can do a lot of things. It's a patient that in 2 weeks he's going to go for 2 months. He's going to disappear. And he needs some stability of the structure. And I tell the patient, we can go look for the screw and try to re-screw through the crown that it's cemented. There's a risk of breaking that porcelain, but we need to access. Otherwise, this problem will develop a new problem, because this screw is holding the structure, and this screw might experience either a screw loosening as well or a fracture. So at this point, you need to go and try to stabilize the situation. And I tell the patient, we're going to go through, we're going to find the screw, and we're going to try to re-screw that screw that is going to fit your abutment into the implant. But we are experiencing here a screw loosening. Potential factors: parafunctional habits, non-occlusal control, excessive activity of that area because of the absence or the lack of dentition on the other side, on the contralateral side. But at this point, I tell the patient, maybe there was a misfit here as well. If there is a misfit of the structure from the beginning, obviously those abutments are going to be suffering for a certain period of time because there is not a passive fit. So for the same reason that we look for a passive fit when we are using screw retained prosthetic crowns, screw retained crowns, we need to confirm that there is a passive fit between the metal portion of the structure, especially when we have splinted situations like this one, to the prosthetic abutments. Because those micro gaps will not be solved by just adding some cement to cover those micro gaps. That cement probably will be removed, will dissolve over time, and that will develop that misfit that you were having from the beginning. So try to take an x-ray with a very perpendicular projection and confirm that there is a passive fit. Not that only that you feel there is a passive fit, but in the x-ray that there is a passive fit. and the most perpendicular X-ray possible. So we access the second premolar by drilling through the crown, and we found the screw. We found the screw, we re-screwed the area, we re-screwed the crown, and we told the patient. Now it's not moving, but probably, since the full structure was moving before, I need to go to the molar as well and do the same thing. We were successful because we actually found the screw. But the patient didn't want to go to the second screw because the patient was feeling that everything was stable. Was that enough for me? No. I consider this case a case that it should have been treated by accessing the other prosthetic abutment and re-screw the prosthetic abutment. Why? Because when I take another X-ray after that, I see my screw that I found and I re-screw in that area, but I still have a misfit. So if I still have a misfit, it's because there is something that is not properly done. And this misfit here is combined with this misfit of the structure of the metal part of the two cemented crowns. So if I see a fit here and not a fit here, it's because there was a non-passive fit from the beginning. In addition to that, because those implants and those crowns were placed 4 months ago somewhere else, I tell the patient, we need to access, we need to redo everything. But before we redo everything, we have to take care also of the implant. This is the CBCT that was taken on the first implant, the second premolar. There is a stability of the tissues, pre-implant tissues, no inflammation, no mucositis, no preimplantitis. But when I take the projection, cross-section of the molar, what I see, absence and lack of bone on the palate, marginal bone loss, and obviously a potential risk of losing that implant. So it's very important to take into account series of things when we are seeing emergencies like this one. Obviously, communicate with the patient as much as possible. First. Second, try to see the bottom of the problem, not the surface. If you're experiencing a continuous screw losing of your crowns, please try to check which is the factor. And probably is a multifactorial effect. It has a multiple factors that are developing that problem. Remember that whether you're using a cemented retained crown or screw retained crown, when you have a screw loosening from the abutment or from the crown, when it's a screw retained crown, that screw is suffering. And if that screw is suffering, probably you will not have too many chances of re-screwing and that's it, and making the patient happy. So I recommend to look for the bottom of the problem, the cause of the problem, that it's making that screw to get loose continuously. Obviously, we've evolved over the years and we have reduced substantially the amount of screw loosening because of the different connections that we have. We started with external hex connections to internal hex connections to flat platform switching, and now we're having a friction fit or conomorph connections that reduce basically the micro gap and micro movement and screw loosening because of the lack of potential micro movement that the connections have between the implant and the prosthetic abutments, or between the implant and the crowns. So first, that one. That would be my first advice. And second, if you are able to see additional problems that the patient might develop, communicate with the patient and tell the patient. You must focus on this as well. Do not only treat this, because otherwise I'm going to treat you with this, and if you don't communicate with the patient about an additional problem that the patient has, the problem that the patient you didn't communicate and you didn't diagnose from the beginning might be addressed to what you did. That would be my recommendation. So in this case, that the patient didn't want to go for the second implant to try to re-screw the second implant, it's something that we need to communicate with the patient. I'm not finishing my job, and it's very important for you to know it. And another thing, if you hand tight that screw and you take an x-ray and you feel the block of your screw, and you take an x-ray, and there is still a misfit, do not apply 20 newtons torque, because you might break the structure of the implant, the platform, you might break something, and especially a screw that has been suffering. So what we did a hand tight. When I saw the block of the screw, I stopped, and I told the patient, if I'm not having a passive hit here, I cannot apply 20 newtons, 29 newtons, or 30 newtons, centimeter torque with a ratchet, because I might break everything. It's very important. So be safe, understand the problem from the bottom, and try to apply as much knowledge as you have. And I hope that you learned new things regards my online daily classes that we are going to have. Thank you very much. My name is Nicolas Arona, and I hope to see you in the next online class here in Dental Surgery channel. Bye-bye.